I'm Lara Williams. This is another episode of Sonographers After Dark. I am joined by Kelly Thorson. Kelly, welcome. How are you?
I'm well, thank you for having me. It's nice to see you again, and nice to talk to you here.
Yeah, you too. So, there's a lot of things we can talk about. I think we kind of talked about a few different topics that I think are really relevant to where we're at. Kind of, the scene of sonography is changing, right? So from when you started, when I started, there's just so many different avenues of learning, pathways of education, different things. I know you manage the lab. I'm not quite sure what your title is now, but director, I think, of the lab at Lucille Packard in Stanford. So
So I actually I was at Stanford for a long time. I'm now at UCSF, and
you
so I'm
are.
yeah.
Wow, I did not know. Did I miss that on your CV somewhere that you
Might
sent me?
might have, I don't know, but it's quite recent.
Okay.
And yeah,
Wow.
Lucille Packard and Stanford Children's is a great place, and now I'm learning new things at UCSF, which is also a fantastic
Also a
place.
very good place. Yes, I've worked with the team there quite a bit as well. So yeah, I had no clue. So that's a big surprise. For some reason, I somehow missed that. I don't know if that was an oversight on my part, but I had no idea. Congratulations. So
Thank
so what is your role now that you are there?
So here I'm a principal sonographer, so really doing more clinical work and
Wow.
while also being able to do educational work. And I think one of the things that I really enjoy is developing labs and kind of pushing the cutting edge. So those are the things I like, and I think at at the core of who I am is kind of a teacher or educator. So I like to um, infuse any of that anywhere I can. So,
For sure. So, that kind of brings me, I prepared a couple questions to ask you because it's been a while since we've talked and since I've seen you. So I just kind of want to pick your brain a little bit, right? When you are, developing a program where you have, highly skilled pediatric echo sonographers and also some fetal echo sonographers in there in that mix too. How does that look to develop that program within an institution? Because sometimes they're hard to find, and you're having to really kind of scramble to bring staff in sometimes. Like, what does that look like for you to build a program up and really get quality sonographers in place?
yeah, I think that pediatric cardiac sonographers, there's a lot of folks in the industry that have been doing it for a long time. But as you know, there's not really there's a couple of schools that specialize in pediatrics, and so there's not really a nice pipeline for students to come in. So while it's great to have sonographers that are well trained and have a lot of experience in pediatrics and congenital heart disease. I think that's really not always the case, and so for me, what I like to do is partner with programs, and at UCSF they actually started a program about 2 years ago, and so and in San Francisco in the Bay Area there's really three programs that are KHEP accredited. And so partnering with those, and we actually, while I was at Stanford, partnered with programs outside of California. So Seattle University and some other programs. But basically, I think the key is to identify those programs that have good clinical and teaching uh, components, and then either use your site as a clinical site, which is mutually beneficial, or talk with those people and let them know that your program is potentially hiring. And so I really like talking to to students and those people that are at the early stage of their career and may think about pediatric echo or fetal echo and make that choice. Well, it doesn't have to be their whole career. Oftentimes, people are going into that route and then spend the rest of their career there. So finding good students and people who are really have a high degree of success in this type of environment is essential. So.
Yeah. I mean, so what do you think it takes to really build the competence level of maybe a new graduate sonographer and train them? Maybe they haven't had that pediatric background at all, and then you're training them from just, a primarily adult echo sonographer into becoming a pediatric echo sonographer.
Yeah, it's a good question, and I think there are different levels. I think that just like everything, there's a range, and but most of the time, to bring somebody in from minimal competence to a high degree of competence in pediatric echo. It takes several years, but to get to the point where they're really can image most things. It's right around a year mark. And so obviously that's a lot of investment both for the individual and for the program. So I think that's why you want to kind of talk with a person or people ahead of time and really get a sense if that type of area or specialty is something that they're interested in and something they want to commit to several years of their career in. So
Yeah, because it's a very long learning path, and learning curve to get where you need to be to assess congenital pathology, and I think that it also takes just a whole different commitment level of the sonographer, as well as there's so many other emotional components, I think, when you scan pediatrics sometimes that can be challenging, not that that component isn't there for adults, it is, but it's different. You're dealing not with necessarily acquired disease, but congenital heart defects, and there's a lot of surgeries and so many different palliations that take place that can be very challenging for the families and for different scenarios where not every child survives, and so this becomes something that is the sonographer has to be able to manage those complex emotions too.
yeah, it's a good point. I mean, I think that as we work in healthcare, death is always a potential and something that we run into. I think it's a little different when you're working with, say, a child or a newborn and kind of around that where they're maybe in a palliative state or maybe that they're may not survive. But fortunately, a lot of what we do is kind of helping to build the pathway with the surgeons and the cardiologists and the rest of the team members for some type of good functional cardiovascular life for these
Right.
families and the
And
children.
that's changed what we do on the, pushing into adult congenital, right? Because that has added a whole other field of echocardiography because patients survive that never used to, And so now we have kind of a whole other specialty that's kind of coming off of that what do we do with those patients, And so how does your lab, whether it was Lucille Packard or where you're at now at UCSF, how have you historically seen that managed within the space, whether that's by the adult lab or by the pediatric team?
Yeah, it's interesting over time. I mean, early on, we would have our cardiologists, and we would see these families and these patients until in their 30s and 40s. And the cardiologists would, even though they're pediatricians, they would see them well into their adulthood. More recently, within the last 10 or 15 years, they've formulated really a adult congenital heart disease program, and most academic centers now have that as a kind of a fellowship program, and have on the adult side uh, the those physicians who see them, and they may be somebody who is kind of double boarded as an adult or internal medicine and pediatrics, or they may just be on the adult side. Um, for in terms of seeing them for echoes, a lot of centers still have the pediatric cardiac surgeons, the cardiothoracic congenital cardiothoracic surgeons see them, and with that they end up in the CVICUs at the pediatric centers. Eventually, I suspect that's going to change, but I think that we're seeing it where things are being built. So a lot of centers have a pediatric and an adult congenital heart disease kind of service, but sometimes the surgical part still comes down the pediatric area. Yeah, it'll be interesting what happens in the future. I think that building those skill sets for not only sonographers but like nurses and respiratory therapy and all the care team is important. It's not something that is easily transferable to even other ICUs. So
Definitely. I think it just kind of changes the whole approach. And it's this hybrid kind of, where does the line get drawn and who's managing the care? I have seen a lot of specialties coming out with, board certified adult congenital now for physicians, but they're very few and far between. There's not a lot in that specialty quite yet. So, that has to be managed depending on where you're at, obviously, with some interesting dynamics. So,
and
as far as for kind of where you're at, one of the things that I've been looking at from this podcast is just kind of career pathways for sonographers, right? So I saw when, you sent me your CV, and I hadn't seen that for a little while. And so, I looked at it and I realized I should call you Dr. Kelly. When did you get your doctorate?
So yeah, I this is goes back to the kind of educator. It's like my uh, the times when I feel the best is when I'm learning, or things like that. So I'm and so I went back to school several times, and the last time, which was now several years, it's been
Okay.
a few years now. I did a doctorate in health sciences, and so that was a doctorate that the focus was. I had a research component, which I did my undergraduate with a research component, my graduate with a research component. And so that was very good for me because I love statistics and research. But the component that I really liked about this program was they allowed you to have tracks, and I was able to have a track that was learning to educate healthcare professionals. So
Oh, wow.
and so there was a lot of uh, um, theory and techniques and how you train adults and in health sciences. And so for me, I think educating, whether it's my kids or children or adults, I think that adults are very different. I think that you have to kind of uh, have that training be almost individualized, probably similar with children. But with adults, it's kind of learning those learning styles and trying to kind of work almost collaboratively to teach on one side and learn successfully on the other side. So.
Yeah. Well, congratulations on that. That's a lot of hard work for sure. on
Okay.
top of everything else that you were doing at the time, managing a lab and, just life in general, right? So, yeah, congratulations. But when I'm looking at these pathways, not every sonographer has their doctorate degree or even a bachelor's degree for that matter, right? Most sonographers are like associate degree level, and some are just certificate level. So, what does a sonographer do to really kind of bridge from everyday clinical into something else, or maybe just kind of increase that pathway from entry level into, maybe doing some research or other things within sonography? What would your advice to sonographers be for that?
I it's a good question, and I think the first thing that I would ask is what are you interested in, or what is the person interested in? Because there, like you said, there's so many pathways and so many things that we can do, even in our subspecialties, where we can be like the person that specializes in aortic arches or something like that, or the person that like teaches fellows or teaches students. And so once you identify what you're interested in and what you like, then I think that you could follow that pathway. And whether it's something that is an academic pathway that leads to a degree, or whether it's just skill building and personal building, I think that those are both equally uh, good things to do. And for sonographers, I think that um, uh, there are a group of sonographers that are kind of bachelor's degree, and then management. I noticed that many managers are bachelor's to maybe masters, and so for me. It wasn't as much as having the degree as it was the kind of process for me. Although it's nice to have a degree. I think that the going through the process and learning and kind of exploring in that way was the neat thing for me. And I now it's like, okay, what's the next thing to explore? And so I think the thing to keep in mind is that whether you've been doing this for 2 years or 20, I think it's important to be curious and really think about how you can continue to learn and explore.
I think that's the key, is always learning, because, I think sometimes, sonographers can sometimes get stuck in their ways. When you've been doing something for a few years, you kind of get comfortable and you get stuck in your ways. But if you can just have a commitment to lifelong learning, even if it's not a degree level, like you said, it's just constantly putting yourself in a position to learn something new, and just learn new techniques or new research coming out, right? I think research is a level that, a lot of sonographers don't really do. And so, how would a sonographer get involved in research projects, whether that's, industry supported or, facility backed, research, whatever that looks like? How would you recommend someone to go down that pathway?
Yeah, so research, I think most sonographers, I think, have a sense that, well, we have to do it with a physician or have to do it as part of something else. But the American Society of Echo has a pathway for their annual scientific sessions that is specifically for sonographer led research. And I'm a large proponent on sonographer led research. I think that first thing that you should do is have a mentor, have somebody who can help walk you through it if you haven't done it before. And that can be a physician, or it can be another sonographer that's done it. And as soon as you are starting a research project, it doesn't necessarily mean you need to be the primary investigator or the first author or whatever. You can work and alongside somebody else who's doing a project, and kind of have them as they're going through the research project, involve you with the components, and really ask those questions as to, okay, how do we do this? What's the next step? Like IRBs and all of those can be a little intimidating, but if you have somebody who's either a mentor or somebody who you can watch the process with, I think that's the biggest probably recipe for success for you. I remember ages ago. My first experience was actually our Echo Lab had and this was a primary children's ages ago. We had a meeting, a research meeting, and I was very new into the field, and I was just so kind of awestruck that they were inviting the sonographers to this, and it wasn't as much as we were just sitting there to be kind of to listen, but we were actually active components of, okay, what are we going to do? How are we going to do this? And I think having something like a research meeting that you have monthly or semi-monthly is a good way to keep people thinking about research. And one of the things that came out of that from my mentors was I kept a booklet, and every time I'm certain that sonographers, as they're doing things, they whether it's a new case or a case they've seen before, they're thinking about questions and like, oh, what is this? And that's a great opportunity to just jot those notes down and then start to formulate a research question from them. And that's the largely how the field of echocardiography it moves forward is by research, and that can certainly be a sonographer. And there's many well published sonographers in the literature. So.
Yes. Yeah. So, I think that one of the things that I was talking with Amy Dillenback from Cleveland Clinic about was just ASC advocacy. Like, I think that it's so important for sonographers who are in echo to be part of the ASC, because I think that that really helps to push forward some of that research, and it helps to network and grow your career too, right? I mean, I think that that is really the one thing. If I had to recommend anything to a new sonographer, it's join the ASE, as far as on the echo side, because it really can help to push you into relationships that might be able to mentor you too. That's the other thing. I think that if you don't have a mentor where you're at, you can find one through networking in the ASE as well. And there's councils and other things that you can take part of as well.
Yeah, the ASE is great. I would say SDMS and the ASE, those societies really have sonographers in the forefront. If you look at medical societies throughout the rest of the world, there are very few that really have sonographers as a part of it. And the American Society of Echo has done a great job at having and making sure that sonographers are represented, whether it's at sonographer councils or at the executive level. And so, yeah, my pathway, I've done quite a bit with American Society of Echocardiography, and I will say that the ability to kind of learn and to grow as a sonographer is great there, and there's a lot of opportunity. And the other thing I'll mention is that echocardiography, there should have sonographers at the forefront and part of the kind of decision of how things are moving forward or what needs to happen, whether it's at musculoskeletal disease or research or caseloads and things like that. And I think that it's really, really important that sonographers actively play a part in it. It's all volunteering, so it's your extra time, but not only does it pay back in what you learn and how you grow from it, but it helps the industry and it helps our field to continue to grow. So.
Yeah, and it gives sonographers a voice, and I think if we don't take advantage of actually exercising that voice, then we can't complain if things don't go our way, right? So be the voice of change, or just kind of being able to make sure that our sonographer group is represented for sure. I was saying, I got my FASE designation in 2019, and then I went into industry, so I couldn't really be on like any councils or really do anything. And so now I have stepped away from industry, and which has been great. And I loved my time in industry. That's where you and I met. It was good. I learned so much just about how different labs work across the country, because everybody does things a little different. I'm sure just even from Palo Alto to San Francisco, things are done slightly differently, So I learned an incredible amount during that time, but I was kind of restricted. I couldn't really serve on any of the ASE councils or anything like that. So I'm putting in my request next year to join. So and put my face
Great.
to
That's
work.
good to hear.
So that's my
Yeah.
plan. Yes.
Yeah, and the FASE designation is a great way to kind of be recognized and give you access not only professionally but in the societies. I think that's a good way to make sure that you can kind of take part in some of these roles at the higher level and of the societies.
Agreed. I think it just shows that commitment level to learning and making sure that you're committed to all aspects of that. I think one of the things that we talked about in our kind of topic conversation leading up to this conversation was that, there's a lot of things that have changed. Like there's advanced imaging that's taking place in pediatric echo that we weren't doing before. Strain obviously has become routine in adult echo. Well, what does that look like in a pediatric lab? What does 3D echo look like in a pediatric setting compared to, maybe an adult setting?
Yeah, it's a good question. And so, in terms of what we can do and when we should, I think those are good questions. And I think there's been a lot of work with guidelines to help answer some of those. I think there's more guidelines coming out to help. But in terms of 3D and strain, when I was more on the management kind of directing lab type of stage, I really wanted our sonographers to be high functioning, and I think that takes a lot of commitment from the leadership and the management, and time from the sonographers, and extra time to sometimes learn and to be able to become competent with those skills. From pediatric echo, I think that 3D is probably something that should be part of every study. And the reason I say that is if you think about 3D echo and where how you can use it for things such as function or functional 3D, and so that includes ejection fractions and volumes and sizes, whether it's the right ventricle or the left or the atria. Then when you look at the other road to 3D, which is anatomic 3D, I think that is really plays well to what we do every day in congenital echocardiography, which is we're trying to understand the types of defects and types of anomalies that we see. And so whether it's an atrial septal defect or a ventricular septal defect or a valve, you can use 3D on those and you can learn more. And so I I don't think 3D actually takes place of 2D, but it's one of those things where with 3D you're able to learn a little bit more and provide maybe a little bit more precise care for patients. And training, I think that 3D um, especially with MPR views with 3D. I think that leads to rapid use of 3D, and I use that myself, and it's what I teach in terms of 3D. And I think that it spans across the types of ultrasound machines you have, whether it's a Philips or a GE or a Fuji or for whatever it is. All of those have these components, and it's really nice that they all are somewhat similar, because then navigating across these other systems becomes a little easier, and then you can use it to provide care for your patients and their families. Now, when it comes to things like strain, um, if you think about the ejection fraction, which is the standard for how we assess the function in patients, the reliability of that is and reproducibility of that is only about 30%. And so if you think about that, that is not good at
No,
all.
not
So
at all.
if you look at strain compared to the reliability and reproducibility of strain, it's up around 80%. So for me, and it always comes back to, well, what would I do for my family, or what would I want done for my family? And that's kind of how I practice is, and I would say that I would much rather have strain if I had the choice of one or the other. Now, I don't think it just like 3D, I don't think it replaces it, but strain is one of those things where you have different pieces of information, and if they're all pointing to the same conclusion, I think there's a lot of value and a lot of power in that, as opposed to if you have one data set, you kind of don't really know. So
Yeah. I think the times where strain in the pediatric population becomes a little bit challenging is when you do have some significant defects, right? So, anytime you have anatomy that, strain is built on algorithms. So algorithms and AI are used to normals. And so anytime you have anything that falls outside of normal, the software struggles to kind of keep up a little bit. So have you found any kind of workarounds for that, or what's your kind of go-to in those situations?
yeah. Well, so you're right. A lot of them are built on algorithms, but if you think about what strain is, it's the deformation, and it's the deformation at 2 points in time. It's systole and diastole. So basically, if you all you're doing is you're taking the length of 2 points in time, and so with whether it's a single ventricle or a biventricular heart, I think that as long as you aren't taking at face value what the automation does, you can say, okay, I'm gonna use it, and I'm gonna modify it to what I think it is. I think that adds not only the human value of it, but it really takes that second level, which is kind of understanding the anatomy and sometimes the hemodynamics or physiology that you're dealing with. And especially for single ventricles, there's really not ejection fractions or fractional area of contractions that are easily used with that, especially 2D, because you have your geometric assumptions that are kind of out the window with a single ventricle. So once you take strain, then you kind of eliminate some of those things. And I think the challenge with it may be reproducing that same image to then apply a strain on. So as long as you're trying to do that and trying to do it regularly, I think there's value in it. And in thinking about both function and strain for many years, I came up with just a kind of how to, because I think that in echo school and even coming out of echo school, it's like, okay, measure an ejection fraction, and it's as if that's just something that we're kind of everybody can measure.
To do
But I think, and if you look at probably the reason why there's a low reproducibility is that people tend to do it a little bit differently.
it.
And for when you're only measuring it for the difference between two diastole and systole, and you don't worry about volume or anything else, you can kind of measure it different ways, and it doesn't matter quite as much. But once you add things like volume, which we deal with a lot, ventricular volumes in diastole and systole. We deal with that a lot in pediatrics. Then we have to have a little bit more precision, and if you want to have more reproducibility, then you kind of have to have the team be on board of doing it somewhat the same way. And then so
Sanity.
teaching those sort of things begins to raise the reproducibility and the reliability of those measurements. And so I think that the same thing can be applied with strain. It's you want the whole team to be thinking about it and measuring and reassessing the automation in a similar way. And I think that that takes a group meetings where you're talking about it, you're going over those things, and maybe having paired learning experiences where you have somebody who's senior, teach a student, and then have kind of cross pollination of those people to other learners and teachers.
Like that cross-pollination. I love
Yeah.
that. So, I was before I went into industry, I was an educator at a hospital system in Florida. And I just kind of want to talk a little bit about education on a hospital level. So how do you implement, like you said, some of this training with strain where you might do a one-off, but like what do you really think is best practice to train, whether that's on new things or just kind of QA, going through quality assurance stuff? What would be best practice, you think, to really kind of bring up the level of expertise within the whole team in a
Yeah.
hospital setting?
Yeah, I think guidelines comes to mind, but guidelines sometimes they're not really at the cutting edge. So if you're working at the cutting edge and you're trying to kind of trailblaze what's next or what's best practices, I think that sometimes you have to start and kind of apply it. And for like strain and even 3D, there's no better way than to try and do it or apply it on normals, because if you understand exactly how it is with abnormals, it's kind of disjointed if you don't really understand or when it's normal. So I think having the sense of apply it all the time, do it all the time, and then have a mentor or somebody, a teacher to kind of show you best practices. With
Mhm.
that, then I think that people really accelerate their learning. Obviously, it takes time and it takes commitment from the leadership to be able to have that be an important part. But I think that if we're talking about the value and what it brings to patients and families, I think that it's pretty easy to make that argument.
And I think that, not that adult hospitals aren't at a place where they want excellence and all, they are. But I think that when you deal with pediatrics, there's just a whole other level of expectation of excellence, right? And so just because you're dealing with the smallest of infants and neonates and little and older ones too, but there's just a different level, I think, an expectation of learning, because it is a unique kind of scenario versus, not that, again, not to say anything negative about adult echocardiography. I love adult echocardiography as well. But it's a different scenario. It's a whole different animal than pediatrics, and I think that because of that, there probably is more buy-in from leadership in a pediatric, center to do the education and the training and the teaching and all of that. And so I do think that there's probably some more buy-in. Has that been, I mean, obviously you were managing a lab as well, so I think there was that buy-in from you at that time, but even administration levels as well. What are your thoughts
Yeah,
on that?
I think that it's probably much easier at an academic center. It
Mhm.
doesn't mean it's impossible at a non-academic center. I think that in people I know and things that I'm seeing, I think I'm seeing it being used pretty broadly. Um, so a couple of things come to mind is there was a time when there was no reimbursement, and now I think there is some reimbursement. So you can pair it with um, the work that you're doing. So if you're adding, strain, or you're adding 3D, as long as it fits in a reasonable pathway for the care of the patient, I think that those are good things to add, especially if there's value in the patient and in the care. For programs that are trying to bring on and use these things, I think that you first have to really identify where you're going to use it, when you're going to use it, and then in terms of billing, maybe you don't bill for everyone that you do, but if your team is learning and they're putting that learning forth on every patient, maybe you don't really need to bill every patient for that, but the learning, that there's so much value in that. And beyond that, once people get to the level of comfort, whether it's with strain or 3D, they can begin to kind of explore and evolve that. So it's rarely the leaders or the managers that are evolving those things. It's the team. It's the sonographers who are doing it day to day, or really understand or are really interested in it, that are able to evolve those things. And then for me, that it's such a great feeling to work with somebody, whether as a leader or as a teacher, and then have them teach you something or learn something from them. I think that's really one of the coolest things.
Yeah, it is. And if we're not learning something, that's a problem.
Yeah.
You know, I try to be open to learn something every day. So, yeah, I guess my last question to you would be, so if you're a, pediatric sonographer that isn't in an academic institution, and you don't really know you haven't done a lot of strain, you haven't done a lot of 3D, that's not really your specialty. How would you suggest to them to learn that if they are not doing it currently in their facility? There's not really a mentor available to them. What would your suggestion be?
Well, so I think going back to American Society of Echo, they have a
Yeah.
textbook on strain, and they have a lot of material that is available for strain and how to do it. There's published work that talks about methods, and even down to things like, okay, what do you want your frame rate to be? Do you want it to be half of your heart rate, or do you want it to be your full heart rate? There's a lot of published data that really explains that. So, and as long as you can have access to those sort of things, I think that that's a good way to start, is start to seek some of those things and look into it. And then like you mentioned it a little bit, where mentors like the American Society of Echo actually will pair mentors together. And so if you're looking for a mentor and you're in a rural area and you don't have somebody to teach, I think that you could specifically ask for those things. Yeah, and then things like LinkedIn and other social networks where you can pair with sonographers, and then with that kind of find somebody who's interested to teach. I suspect that you'll find a lot of people who would easily share that information. I think, and you mentioned this in one of your recent podcasts, there was a time when people would kind of hoard information, or people were not really interested in sharing. But I don't know that that's really what's happening now. I think everybody is really interested in sharing, and I think that whether it's myself or other sonographers that I know, I think that they're always eager to help share what they know. So.
And I think also, one of the things I've talked about in a previous podcast too was sometimes you have clinical application specialists, they're trained to do these things on these systems too. So I think that's another resource that's a little underused, because some of these application specialists are brilliant. They really know everything about that system and how to make it do everything you need it to do. So I think that's another level of training that maybe you could reach out to your, vendor and get them to come on site and do a training on site with 3D if you need that hands-on. The other thing too is the ASE has like learning hubs, and they have also hands-on during the scientific sessions where they'll teach you how to do 3D. So I think that, you know, you're not out of options if you are in a rural setting and you don't really have someone right there with you. There's a lot of ways that you can go about getting the education that you need. So thank you. That was a great point. I had forgotten about the mentorship that ASE actually has that. They'll actually give you a one-on-one mentor, right? Again, I couldn't participate in any of that because I was in industry for so long. So I need to look back into that. Thank you for reminding me.
Yeah.
Yeah.
Yeah. And your clinical apps people, they're great. I think I should have mentioned that, but I can't recall how much I've learned from them. And I think that having them help you, and it, you know, they can come on site and spend a half a day or part of a day or a few days with you.
Yeah.
And that's a very, very useful thing to have. And I think that most clinical apps, and I don't know but they have some time or they can make some time where they can come in and help share that information or how to use the tools on specific machines.
Awesome. Well, thank you so much for your insight kind of into how you've done things and your history and your career. You've had an incredible career. So I just I looked at all the papers that you've been published on. Incredible career. I'm like, you know, ultrasound goat. So yeah. But thank you for joining me. I so appreciate it. Any other words of advice or wisdom that you want to share before we sign off?
No, I think it's been fun to talk, Echo, and to talk to you. And I think that in terms of information and learning, I think that things like this are just another way for us to kind of share and to learn. So it's really cool to see.
Awesome. Well, thank you for joining me. This has been another episode of Sonographers After Dark with Kelly Thorson. I'm Lara Williams, and I'll see you next time.